Okay, so we can start the lecture. So I'll be going over some very basic stuff of the cardiac MRI today. So cardiac MRI, the MRI means magnetic resonance imaging. There are many types of magnetic resonance imaging. Nuclear magnetic resonance imaging, called NMR. And it was actually devised in US, not very far from here in Stony Brook in New York, by these three people, Raymond Damadian, Paul, and Peter Mansfield. They shared the Nobel Prize for this. Just a background. So what happens in MRI? So in MRI, they found this phenomena that the body or anything can be magnetized. Someone is not mute. I cannot. So please mute all of the people. Please mute. I'm having a lot of feedback. So the body can be weakly magnetized, and whenever you make the body change into a magnet and you move the magnet around the body, it gives us a signal. And this is what the discovery was that led to the discovery of MRI. So what they found was that if in the Earth's magnetic field, which is thousands of times less than the MRI magnetic field, the body has very, very weak magnetic value. But when you put the body inside of a MR system, MR bore, which is 1.5 Tesla or 3.0 Tesla, we have both at UMass, the body gets magnetized. And as you can see here, the B, which is the direction of the magnetic field towards the head of the body, is directed this way. So the protons in the body, many of the protons in the body start going in circles with the axis in this direction. And when you bring the body out of the magnet, these protons go back to their haphazard motion again. So they found that when they go back to haphazard motion, they can detect a signal out of it. Now, in real MR today, there are gradient coils, which also give some form of radio frequency signal, which can change the direction of those protons. I should actually, I'll go over this again in a bit, just to explain this. So as you can see in the A figure, the protons, their north and south poles are in every direction. When you put them in the magnetic field, half of them start going with their axis towards the north, half of them going the opposite way. Now, some of them are more in the north direction, in the direction of the magnetic field. So every million, with every million protons, there might be 6 or 7 protons that are directed more towards the north because of the magnetic field. So this is the extra magnetization. What does magnetization means? That the body changes into a north and south pole, just like a magnet. And when it's directed in this direction, in the upward direction, then these are more in the north direction. So when the magnetic field is taken away, they will go back to the same value, and there will be equalization of the north and south pole. But when the body is directed inside the bore, there are more protons spinning in the northward direction, and these protons are the ones that give us the signal. So what we do is that, let me open Paint. I don't know. you can look at the, where's the share screen? So what I was trying to say is there are 106, I'm just making it up, okay, protons directed this way, which have a spin like this, and there are 1,000 directed this way, sorry, 1,006 the other way, this way. So what happens is that these protons are bombarded with RF, so this is the proton, RF signal, which is basically a radio frequency signal. And this signal has to resonate with the proton frequency, which is around 64 megahertz. When it resonates with it, it can flip this axis to something like this, change an angle.
Dr. Qureshi, are you writing something? I mean, I cannot see it from my screen.
Oh, okay, sorry. Oh, no. Can you see this?
No.
We can't.
Oh, no. Let me see, how do you do that? So if I do resume share, what are you seeing right now?
Oh, we can see it. You're writing something on this page.
No. Okay, let me clear all of that. So what I was saying is, thank you for letting me know.
Thank you.
Okay, so I was talking about, so this is north and south, right? So in the direction of the head of the body, there are 6 more protons every million in this direction. So what we do is we put a RF signal, radio frequency signal, which should resonate with the, it's usually around 64 megahertz with the proton signal. So if the axis is like this, it will get tilted like this. And we know the computer on the MRI machine tells us what angle it's going to flip. So when it's tilted like this, when the proton is tilted in this direction now, so it's spinning now like this, what we do is we remove that radio frequency signal. It stays for a few milliseconds. Now what happens is, because the bore of the magnet is still present, so this starts going back like this again. This time, which is changing, which happens at this time, there's a loss of some energy, and we can find that energy in a magnet, and we can change it into a signal, and which can make an image through something called Fourier transformation. Okay. And I can always explain in more detail, but just to let you know that Fourier was a mathematician. He found that this waves that come out, how can we change them into an image? That's the simplest explanation. So the wave changing into an image, which happens in the TVs, in any imaging out there, we should be thankful to this guy. We can make up an image from the waves. He explained and that how can we can change one different waves into equivalent voxel or pixel. These are the words we use. So voxel is used a 3-dimensional image in case of MRI. Now this, going back to this same direction, happens in 3D, right? And that 3D happens. So one thing, it happens at the x-axis, and one change happens in the z-axis, and we have different times for these, and these different times are called T1 and T2. Okay, so going back, let me see, new share. So can you see this? Hello?
Oh. Yes, we can see the slide.
Okay, see this slide. Okay, perfect. Okay, So these are called relaxation processes. Okay, so going back to the net magnetization vector, which is inside the bore, is called relaxation process. So if it happens in longitudinal axis, which is the y-axis or x-axis, then we call it T1. And we have picked up a cutoff, which is 63% of the initial energy state that it was, that we take that time. Because when it's going back, it's taking time, right? So that what percentage of that time we take it as 63%. And when the transverse relaxation happens, T1 is back to the z-axis. I got it opposite. The transverse happens in the y-axis. We call it spin-spin relaxation, or we can sometimes use it decay of the magnetization vector, and it's called T2. Okay, so in XY plane, it happens way early. So T2 is usually smaller than T1. T1s are in thousands for myocardium. For the T2 will be in 50. So almost 25%, 25 times less. And these T1 and T2 times actually tell us that what type of tissue is it. And they have different characteristics. And we have given them the shades of gray on the MRI. Does anybody have any question here? Does anybody have any question here? Because this is important concept of MRI. So as you can see in this image, everything is directed towards the z-axis. You flip it at an alpha angle, and you can see it on the MRI images. They give that angle, and then you put the either alpha degrees of pulse or 90 degree of pulse. So many of the T2 images we put 90 degree of pulse. So a 90 degree of pulse will make it start spinning around along this red line. And then what happens is it goes back to the z-axis. Now here they are showing that sometimes we push two different pulses, one 90 degree and then followed by 180 degree. This is called inversion recovery sequences. You might have heard IR sequences, or you will hear that. So what does this do is it makes the proton give a wave that is more of a T2 characteristic. So we can use it for T2 weighted imaging. So I think that's much. I can go in more detail in the physics, but I think that's good enough for you guys now. And we can always discuss afterwards in questions. So the advantages of CMR over other cardiac modalities are there's no ionizing radiation. It can heat things up a couple of degrees when you are doing the case. And we know how much strength of the field is in the body, and we can change that. So in pacemaker patients, or where there are wires in the body, we can change a setting in the MRI where we can have the MRI magnetic waves weaker in certain portion of the body that it doesn't heat it up. There's you can choose any imaging plane to do it, but it's not like CT scan where you can do a 3D reconstruction in this. We usually do not have 3D reconstruction available, so that's a downside. It's in research, it's available, but you have to take a plane through which you are imaging, just like echo. If you do not take a plane, then you cannot do the proper imaging, and that can happen in MRI. Then the other thing is the most important thing for MRI is that you can characterize the tissue, and you can also look at the motion of the blood, and you can quantify really well the ejection fraction. Many of you might have heard that MRI scan in the past used to be the gold standard. This is way better than MRI scan. Okay, so the gold standard of calculating EF now is MRI. And then it can also look at the perfusion of the different portions in the heart, which is a plus as well, which on CT scan, you don't see it very well, or other modalities or echo. So like I said, 1.5 Tesla is about 30,000 times that of Earth's magnetic field. It's very important to be safe with this. Anything near the inside the room of the MRI is either going to get pulled into the machine or fly into the machine. If you're really close, it will fly into it. And inside the machine, they might experience some torque as well. So if there's a bullet in the body, it might start moving in the MRI. Rapid change in the field, because the field is changing whenever you are doing imaging, that can cause the magnet to get stronger or weaker. So that can also pull things very closely with this. The other thing I talked about was that it can cause heating. If you actually, I'm going to ask this from you guys as well, that we actually need some healthy volunteers, and I'm sure most of you are healthy, male and female volunteers, for actually getting T1 weighted values of the heart. So if anyone would like to have their MRI of the heart done as a volunteer or as a help to our program, I'll really appreciate it. Let me know. Okay. 4% of the patients can have claustrophobia, and that's a big issue. So usually we give some form of sedatives before taking them to the MRI. In some places, it's difficult to give IV medicines without the presence of a physician, and usually radiologists do not call themselves as physicians. So you need to have another physician on the bedside to give those medicines. So I'm sorry, I wanted to say, like, they want another physician at the bedside. So there are a few other concepts of MRI. One of them is cardiac gating. And this is a very important concept because it can cause a lot of issues with the images. What cardiac gating means is you are using the ECG to get the images. So you might have seen, if you take a picture of a moving kid, it's blurred, right? So what we do in the case of cardiac imaging is that we only take images at certain point in the ECG, in the RR interval. So the R wave is very, very important. If the R wave is small, we might not be able to get the good image. If R wave is haphazard, like in atrial fibrillation, we might not be able to get good images, especially at high heart rates. If someone is having a lot of PVCs, we might not be able to get good images. So all of these things need to be controlled before they show up in the MRI, because MRI is slow in taking pictures, slower than CT scan. So we need to get good images. And there are different types of gating. One is prospective gating, where data or the information is obtained at the start of the cardiac cycle over several cycles, and then it adds up and makes an image. While retrospective gating is you are continuously acquiring the data, and then in the future, we post-process it and obtain this, the image data from that. It's good for cine images. It's less sensitive to arrhythmias or PVCs or TACs, and it's better for regional and global wall motion assessment. But it's not good for temporal resolution. So as you can see here, that one of them is gated and one of them is not gated. And you can pick it up, right? The upper image is much better than the lower image, and it's not gated. So that's how you will see. Now, there's another form of gating, which is respiratory gating, that is also very important in MRI. In CT scan, you just take a breath and the image is done already. While in the MRI, we obtain images in expiration most of the times. You can do inspiration as well, especially in the patients with pacemaker. You can do an inspiration because the pacemaker will move up, but otherwise we do all the images in expiration. And usually 10 to 15 seconds is what we need. And that might be a lot for some of the patients who are short of breath, who cannot lay flat. So in those patients, the images are distorted, they are not great. And the reason for this is so that the diaphragm is staying still while you are taking these pictures. As you can see in the imaging with breath holding at the end tidal position, some of the patients, especially the kids who cannot hold breath, we might end up actually putting them under anesthesia and then doing the case. And anesthesia can make them stop breathing during that. Now at UMass, we are able to do it now. It's case by case basis, and we have successfully done few cases. So if there are any concerns, we have to set that up in before going to the MRI suite. So these are some advanced things that we do not have available, but you can track diaphragm and using respiratory navigator and other things that can take into account. So I wanted to go over what is pulse sequence. So I just talked to you about that the radio frequency pulse that we give, which switches or flips the angle, is a part of a pulse sequence. And you have to apply these sequences in certain form to create an image. So a pulse sequence is a combination of radio frequency pulse, magnetic gradient field switch. So there, inside the MRI machine, there are something called, we have gradient coils. What they do is they change the magnetic field across the inside the MRI machine. So let me share this again just to show you. Okay. Can you see this? So this is MRI bore. You guys are seeing this, right?
Yes.
Okay, thank you. So this is the table. So there are coils like this in the MRI. There are lines of wires. And what happens is that inside the MRI, okay, another bore, you might have here 64 megahertz of, or 1.5 Tesla of gradient. But here, it might be 1.50001. Here, 1.50002. And the other way, you might have 1.499, something like that. So what that does is that we know exactly the location of the information that we are getting from. And that's what the gradient coil is for. There are other reasons for the gradient coils, but they give us a three-dimensional information inside the body. And we switch them, the gradient coils, depending on what type of information we are getting. And they have to be in a precise order to get that information. Now, the newer computer systems, they already have these built in. You just have to click and pick it up and it will do it. But you need to know what sequence you need. And there are some modifiers of this that we do to obtain certain information, for example, flow, for example, cine, and all that stuff. So these are different type of sequences. And these, as you can see, I've just put like the most common ones. There are many more, but just to go over these. So the first one, as you can see, is called spin echo, and there are different names for this. And every vendor, like Siemens or GE or Philips, will have their own names. But what it's doing is that it's creating change in the spin, and there is an what we call echo train in the middle, which means there's increasing and decreasing levels of gradient applied on the body to obtain this. And I'll go over why is it used, what's the value of this. But spin echo gives you very good spatial resolution. It's really good for morphology. You can see the structures really, really well. So in the beginning of the imaging, you might see this image, which gives you an anatomy of the whole area that we are imaging. Then there's something called gradient recalled echo, and there are multiple types of gradient echoes. It does not have really good spatial resolution, but it's really good with when the imaging has some issues with it. And I mean, we can talk about those issues and that later on. But the issues, for example, pacemaker, you want to get a gradient echo in those patients, because gradient echo does not change a lot of sequence radio frequency, because in spin echo you might need 2 radio frequency signals, so it takes long. Gradient echo is quicker, and you might not magnetize too much, so there might not be much artifact from things. So gradient echo is really good in those patients. It's quicker, it takes less time. If the patient cannot take long breaths, then you can use gradient echo, and it will give you the same type of T1 and T2 imaging that you want. Then the other name you will hear is called steady state free precession. Precession is the name of the spinning, and this has different names in different vendors. Again, some people call it some companies call it TrueFisp, some call it Fiesta. We have Fiesta available in our scanner, balanced FFE, and this is mainly used for function, cines. The cine imaging that we see, as you can see down there, they're example images. GRE is a gradient echo, SSFP is the other image. Gradient echo does not give you very crisp imaging, but SSFP gives you very crisp imaging of the myocardium, and you can estimate the EF on it. So SSFP is mainly used for EF assessment, motion, wall motion abnormalities, and things like that. Then there is something called mode. So mode is dependent on the ECG gating. And if we are obtaining something called single shot, it's like a snapshot, like a quick picture, okay? And we, in patients who have arrhythmia, single shot will not work very well, okay? Because it's taking a single picture in 1 or 2, mostly in our scanner, we take pictures over 2 beats. So that's very, very quick. While in patients who have arrhythmia, you want to do segmented imaging, because what happens in this is that it acquires piecemeal data over several heartbeats. So every heartbeat, it will take some amount of data, and the image will get clearer and clearer with every beat. And that's how the image is obtained on this. It has good high spatial resolution and high temporal resolution. So I use segmented whenever, so you have to tell the patient, the scanning person, that you want segmented instead of single shot images in patients with atrial fibrillation, especially mitral valve disease patients, they have atrial fibrillation. So you want to do that in those patients. Otherwise, single shot works for most of the patients. Then there are modifiers. As you can see on the right side, right-hand column, something called black blood, where we make the blood change into black color. As you can see, there's example down there. The blood is black. So that, what does that do? It helps us look at the myocardium really well. So this is again used mainly for structure, and you want to use this for structure. So pericardium, is another important thing that you want to see on these images. Myocardium you want to see on these images. Any structural abnormalities of the vessels you want to see on these images. The aorta is measured on these images as well. The aorta looks black and very nice with crisp adventitia, so you can measure those things on this. Then comes something called fat suppression. What is fat suppression is that what we do is because there's a lot of fat in the body, and fat is very close in T1 and T2 properties to water, and you don't want to you want to distinguish it from other cardiac structures or contrast as well as the fluids. So what we do is we give another RF frequency, and what it does is it makes the fat change into a blackish color. So in fat suppression imaging, especially we do it in the T2 weighted images, you can distinguish between edema, water, and fat. Because the fat will turn black and edema will still be white. I'm going to leave the inversion pre-pulse and saturation pre-pulse. What is T2 prep or long echo time? This basically means, so once you obtain the data, you are giving a pulse sequence every certain period of time, so that you will see the TE written on MRI picture. In T2 weighted images, you have a long echo time. And what does T2 do? It helps you identify anything with edema, water, and especially the inflammation, if there's myocarditis, there's myocardial infarction, you will see elevated bright signal in the myocardium in these images. T2 mapping is another, T2 star mapping and T2 mapping are other sequences. What they do is that they actually give values of T2 to every part of the myocardium or of the image, and you can actually measure the T2 values of myocardium. And certain values would signify that someone has iron overload. So we use the T2 star value for that, which is a similar kind of number as T2. And it would be if there's iron in the myocardium, what will happen? The iron interferes with the protons a lot, with the hydrogen atom protons. So it will make the T2 relax in the transverse axis way quicker because of their presence. So the T2 number will drop significantly. So below 30, you start wondering if there's iron overload. Below 20, you are pretty sure that there's iron overload. And below 10, you have to consider chelation therapy in these patients. Then comes something called velocity encoding imaging. This is similar to echo Doppler technique, where you can actually measure the proton motion or movement in a certain cross-sectional area. And that will help you identify the velocity through the valves, through the shunts. You can calculate QP over QS ratios. You can calculate cardiac outputs through that measure. So one of the way to measure the cardiac output is by measuring the ejection fraction multiplied by the heart rate. This is the second way of calculating the cardiac output, and they should be close. So the flow in the aorta should be the cardiac output, right? unless there is some issues with the aortic valve or the mitral valve. There's mitral regurgitation, it will drop. But otherwise, the cardiac output calculated in the aorta should be similar to that of the measured from ejection fraction. Parallel imaging, we do not have that available, but what that means is at the same time, we are getting a lot, like many MRIs done at the same time. So you can do imaging by a factor of 4, which means you're getting information 4 times per beat. We are getting a coil. I'm hearing this, that we are getting this coil since last year, but hopefully we'll get it, which will help us to do it. Right now we can do by a factor of 2 only. Then there is something called tagging, which, as you can see down in the rightmost corner, tagging is something that we put pulses inside the heart or the myocardium and null them, make them black. And the reason for doing this is that we want to see the motion. This just accentuates the motion of the myocardium. There's a very nice case from last Friday. Dr. Orijama told me about that case where the pericardium is adhered to the myocardium, and you can see that the myocardium is not really contracting, and this tagging really accentuates it. You can see it very clearly. So that's what tagging is. So I just put one.
Waqas, can I ask you a question, please? Waqas?
Yes, I can.
If you go back a slide, way back when I was a fellow, we had the gradient echo imaging, which we used to call cine MRI.
Yes,
would you say, is it a fair statement that the Fiesta or TrueFist has basically replaced what we used to call gradient echo? The images look similar, but do we do both in a given examination? Do we do both?
No, we do not do both. We do preferably SSFP. There is a difference. There is a difference. It's in these pictures you cannot see it, but the differentiation between the blood pool and the myocardium is different. So gradient echo is inferior to SSFP. Okay. However, in certain cases, as I said, we might end up using gradient echo because it's quicker if someone is having arrhythmias, someone has pacemaker placed. SSFP gets distorted a lot by any artifact.
Okay.
Yeah.
Thank you.
So that's the reason. And SSFP, it's really good for trabeculations. For example, this I'm blanking a lot of things out after this COVID. The
non-compaction.
Non-compaction. You got it right. There's telepathy going on. So yes, non-compaction. It's really good for those. For thrombus, probably not that good. So you might not be able to see the thrombus because the blood pool is much brighter on this. But a small thrombus, large thrombus, you'll see it. The motion of the thrombus, you'll see it, and it has better temporal resolution than the gradient echo as well. So there are advantages. You get 25 to 30 cycles in when you image this. So that's the temporal resolution we get per beat. So I was talking about this sequence. So most of the times I put this up there, although we do not do this stress sequence, but what our imaging is that first we do a scout sequence. Did I have that? Yeah, scout sequence, and then we do something called functional volume assessment with Fiesta SSFP imaging, and then we give contrast and image after the contrast. Now, in the middle of this functional and the contrast imaging, we can do different types of imaging that might include flow velocity imaging. We can do some morphological imaging features that, like, we can have T1 weighted, T2 weighted images, or T1 and T2 maps. So that's mainly the MRI examination sequences. So scout films, then blood imaging, then functional volume imaging, then contrast imaging, and we add T1 and T2 sometimes depending on what we are getting. So scouting, the first procedure, it mainly is, like I said, we cannot do 3D imaging in these patients. So we have to find an axis through which we are going to take pictures. And that axis should be through the apex to get perfect imaging. These are single shot images. And after this, we would do SSFP imaging. So this is an example. As you can see, you want to have this plane, which first we get the 2-chamber plane. So you'll see 2-chamber images in the beginning of the MRI exam. And through 2-chamber, we cut it in the middle with the mitral valve line going through in between the mitral valve going through the apex. And that will give us a 4-chamber image. And once we get a 4-chamber image, right in the middle, we cut it to get a short axis sequence. And on the top, you can see the coordinates. So we get sagittal, coronal, axial, and through the axial, we get this 2-chamber image, basically. And then the whole of the examination is through those. So if you want to change, if there's a mass or something, you have to tell the person who's scanning to change these planes. Otherwise, you will not get it. If that thing, what you are looking at, is not in these planes, you will not see it. So that's very important. So if you are looking for hypertrophic cardiomyopathy, you have to have access through the aorta and LVOT. Otherwise, you'll not see it clearly. We also do 3-chamber imaging. I like to do things like echo, but some radiologists don't do it. But it's to them. So, like I mentioned, so cine. So the first sequence after the scouting is, most of the times we look at the structure with the black blood. I didn't put it there, but this is like always there in any MRI image. We get a cine MRI using GRE, gradient recall echo, gradient echo, which Dr. Arijema mentioned, or SSFP. And it's basically a moving heart beat. And they're about 2 to 20. I mentioned we have 25 frames per cycle. And it could be 35 to 45 if time allows. But every cycle, we can get about these images. So pretty good information. We get usually 30 frames per every beat. So you can see the end diastole and end systole on those. These again can be, the mode can be single shot or segmented depending on the heart rhythm. And we get 2 axes, as I mentioned, 2, 3, and 4-chamber axes on this. And we used to do slices about, so we try to get 6mm slice, but it's really 8mm to 1 centimeter slice. So every image is about a centimeter, which means that you can miss things. So if a millimeter, or like on the TEE, the resolution is around 1 millimeter, you can see those things on TEE very well, but on the MRI, you might not be able to see it. So MRI is not superior in finding things if someone wants to find things in the heart in small size. So as I said, this is like 2-chamber views. I think I wanted to stop here. Did have another slide set that I wanted to go over really quick. Okay. So I went over dark blood and bright blood sequences. What are those? So black blood which tells us about the anatomy. And you will see that in the beginning of the imaging is mainly spin echo, where the blood has been changed to black. Bright blood, so SFP, SSFP, and gradient echo for the volume assessment or motion are bright blood. So we don't talk about T1 and T2 weighted imaging in these sequences because every image is using both T1 and T2 times. So you cannot say which one is more. So what people started doing is that they just made it simple. If the blood is black, it's black imaging, black blood. If it's bright blood imaging. And then I was talking about the velocity encoding, where you can actually measure the velocity. We call that phase contrast imaging. That's the name, phase contrast. It's like Doppler. Then we also talked about the contrast imaging after the contrast, which is what we call delayed enhancement imaging. And then there's magnetic resonance angiography, where we use gadolinium most of the times to get imaging, and it's called spoiled gradient echo. It's type of a gradient echo, but it uses a different radio frequency sequencing than a gradient echo. And then tagging, which we talked about. So blood imaging is something like this, as you can see. They are produced with MR pulse sequences that null the signal from flowing blood for better visualization. Really good for cardiac and mediastinal anatomy. Gives information about pericardium. So the thickness of the pericardium I measure on this imaging. It also tells you about the aortic disease. So aortic values, like someone has aortic dilatation, I measure everything on this, the aortic values on this. They are both, as I mentioned, T1 and T2 weighted spin echo sequences. Mostly it's more T1. Okay, so the ones where you see the myocardium is like grayish like this, it's T1 weighted. But I don't use the words for T1 weighted. So I was talking about this before. In spin echo, you give two pulses. First is a 90-degree pulse, then a 180-degree inversion pulse. And what it's doing is it's making a wave come out of the protons that will give information much better than just one pulse. Because every time you give a pulse, the protons align, and you want them to focus along one axis, because you can only get information in one axis. If they keep on becoming haphazard, then you don't get much good signal. You don't get a good signal. So you align them in 90 degrees, and then you invert them in 180 degrees. So every time they give you double information, and then you use it to make the signal, make the image. It's 1 o'clock now, and I'll go over. I have much more slides. Let me see, yeah, 96 here. The next time, but if there are any questions, I'll take them right now.
Waqas, can I just ask you a quick question on the
Yes,
on the black blood imaging?
Mm-hmm.
Will black blood imaging, the spin echo imaging, does that give you any T2 information?
So you can image, it doesn't, the shortest answer, but okay, you can change the sequence in a way that you can have T2 weighted imaging. The issue with that is that the myocardium becomes very black. It doesn't stay gray, and many of the things become darker. The other thing with the T2 is you have to have a longer breath hold, and it sometimes, it doesn't give you really crisp images as the T1 weighted does, because the time to echo, as I mentioned, is shorter, so you can get more sequence or pulses and you get more information and more nicer image, versus if the echo time of every pulse is long, as in T2, it will distort the image a bit. So that's why we don't do, but yeah, you can change it in a way to get it, but it's more like we don't really use it.
So is it fair to say that the spin echo black blood is primarily T1?
Yes.
Okay. That's kind of what I had in my mind, but I wasn't 100% sure. Okay, thanks.
Okay. What about the fellows? Are fellows there, or they are all sleeping? I usually have the interactive version of this, but
no, this is great, Vikas. You know,
Thank you.
I've been at UMass more years than I'd like to mention, and I think this could be the first time one of our faculty has given such a talk. So thank you so much.
you're welcome. This is very basic for you, Dr. Rajaman, but
well, you'd be surprised.